we're drinking too much juice or milk or coffee, those things can sort of gum up the secretions in your lungs and make it harder to breathe. And then we also try really hard to address other health conditions that can complicate COPD. One of the big ones that we address is sleep apnea. We also address acid reflux and heart failure, because those conditions can contribute to, sleep apnea can contribute to the way how well or how poorly you're breathing during the day. It also puts a lot of strain on your lungs if you're not breathing well at night, and it puts a lot of strain on the right side of your heart. And then the heart and the lungs are always interconnected, and so you can't really address one without making sure that you're addressing any issues with the other. So, sort of last but not least, how can we help? My position at Pulmonary Associates, and I have a counterpart who works on the north side of the river at our Santa Rosa clinic. I'm in the Boulders clinic, and we specialize in COPD. So I see patients who have chronic obstructive pulmonary disease all day, every day. I see patients as they come out of the hospital, and then my job is also to do sick visits to make sure that you try and stay out of the hospital as well. And then I also see COPD and follow-up appointments. So anyone who has COPD can be seen in my clinic. We have a little bit longer visits, which allows us to go through medications with our patients. So, if somebody comes in and says, I've been using this for years and I really have no idea what it does or why I'm using it, then we can kind of go into that and figure out, okay, is this really helping you or is it not helping you? We can help work out some of the kinks with medical equipment and figuring out, okay, do you have the right thing? Is there something else that you need? And kind of talking to you about your day-to-day life and saying, could you really use a shower chair? Would that really make a huge difference for you on a day-to-day basis? The other thing that we do is we refer patients to other resources. We refer patients to Breathmatters. We can refer them to our sleep clinic if needed. We can get you set up with primary care. There are a decent number of folks who come to me and it's their first interaction with their healthcare, with the healthcare system, because they're either newly diagnosed with COPD or they've been fine for a whole lot of years, and then they get this wicked pneumonia that kind of throws a wrench in things. So we can help set up folks to see a cardiologist or a primary care doctor. And then once you see me, after you see me, I set my patients up to see a pulmonologist. So you will have a Dr. Rajan or a Dr. Radau or any one of our physicians. We transition you into their care. So my job is not to replace anyone's pulmonologist. It's really to be a supplement, to be an added benefit for patients, so that we can help prevent folks from going to the hospital and maximize your quality of life. So all that said, do you all have any questions? Yes, go ahead.
I'm wondering, is there ever going to be a COPD clinic at St. Francis or on this side of town?
So the Boulders Clinic is right next to Chippenham. There is not one by St. Francis right now, but I see a lot of St. Francis patients. And there are also 2 new nurse practitioners there. They are not strictly dedicated to COPD, but I know they would be happy to see COPD patients. Or you can always, patients can always come to me, and then I can transition them back to their care provider who normally works at St. Francis. I do that lots.
Are you receptive to having anybody come to your facility just to do a visual of what you have to see if it is a good fit for them?
Yeah, definitely. Just to kind of hear about the clinic,
Yes.
or yeah, sure.
That was a good presentation, thank you.
Yeah.
Excellent.
Did you have a question?
I do. I actually went and saw, is your cohort that you were talking about, Megan?
Mm-hmm.
Okay, I went to see her last week, and I have to call her today. What's the difference between just getting short of breath, pretty severely short of breath on exertion, walking up steps, walking up hills, and with no wheezing? My problem is I get I've had asthma for a very long time. I now have COPD, and according to my pulmonary function tests, I'm pretty low. I'm in that very severe
Mhm.
category. But on a normal day-to-day basis, I get along okay. I can walk. I used to be able to walk 2 miles. I haven't been able to do that for over a month. But I just gets gradual. I can see myself getting more fatigued. I can see myself getting short of breath if I walk up a flight of stairs or a hill. But I don't wheeze a lot, or I don't wheeze at all. And then when I'm sitting, I'm perfectly fine. So my issue is I call the doctor and I go to the doctor and they go, oh, you got air moving, you're not wheezing. You're fine, but if you see me walk any sort of distance, and I happened to see Megan on Thursday. I called and Dr. Jury's next appointment was March the 20th, and that obviously is not going to help right now. So they said, well, Megan can see you at 3. So I went that day. It was wonderful. I think the clinic is wonderful. And, you know, she said the same thing. She's like, well, you're not wheezing, and I hear air going through there. And I said, yeah, but, and I'm still like dependent. I'm on prednisone all the time. So I talked to her again on Friday, and she did give me an antibiotic, and the prescription she sent me for prednisone, she was going to do a taper, or something got messed up because they didn't send the right thing. They sent one for 5 milligrams every day, which is what I do all the time. So I got to call her today. But I just, you know, even though I've had this problem for so many years, I still find that I either go to the doctor too soon and they say you're fine, or I wait too long and they say, why'd you wait so long? Your fingernails are turning blue. And that's the truth. And it's because, you know, I know if I go and I sit and wait for them, they put you in the room and you wait 5 minutes and I'm fine.
Yeah.
And then I walk to my car and I can't breathe. But they don't see that.
So something that I am learning is a very important thing to ask patients is how is today different for you? Because some people wheeze, some people don't. Now I have patients with COPD who've never wheezed a day in their life. And so figuring out what is different for you on a day-to-day basis. And I say to my patients, you know, if your shortness of breath, if your breathing gets worse, if you're getting more winded, then something's going on. And you don't necessarily have to wheeze for someone to say, you know, you're exacerbating, you're getting sick. I think that there is some hesitation amongst providers, including myself. If I don't hear a patient wheezing, then I'm maybe a little bit hesitant to prescribe a steroid. But everybody's different, and we try pretty hard to listen to you to say what has changed, what is different for you. Even if you're not wheezing, if you're more short of breath, then that's different for you, and that's probably a sign
Yeah,
that you're
it's
getting
not
sick.
just that.
The other thing that office can do, is an exercise oximetry
Yeah.
test, where they'll have you walk up and down the hall.
I've done the 6-minute walk test. I've done
Your
that.
oxygen
And I mean,
level-
that's all flat.
Right.
6-minute walk test is all
Right.
flat.
They have some good staircases in Santa Rosa.
They
too.
do.
Yeah.
And at one point, this was not my pulmonologist, my primary care physician, who really has taken very good care of me. He's since retired, but one time I got frustrated with him. He said, Joan, you got air moving, you're fine. I said, I'm not fine. Walk up a freaking flight of stairs with me. He did. He put the pulse ox on. He said, okay, come with me. And we walked up the flight of stairs. It went from 98 to 82 on one flight of stairs. And he looked at it, oh,
This
yeah,
could
you're
be
right.
and then being an advocate, you know, for yourself, and also exploring if they say, well, I hear, the first thing is, not just wheezing isn't enough, because you may have, you know, wheezing because you have an air movement, right? The difference between not wheezing and the air.
Right.
But they say, I hear the air movement, I'm not hearing wheezing, I don't think it's your COPD. The next question is, well then, what is it? Could I have maybe some underlying heart failure? Could I have a leaking heart valve? What else could be causing this?
Yeah.
You know, are there other potentially life-threatening things, like a blood clot, that can cause excessive breath in a lot of people know this. You know, there's a whole slew of things that if it's not this, then, you know, well, okay, I'm gonna go home now, well, then what else can you do? It sounds like, you know, you seem to be pretty much advocating and saying, okay, it's not this, what's next?
And I think that comes from my experience of getting frustrated with what others say, you know, and I can tell the difference. And see, it gets very gradual, it's very gradual, like this has already been going on for probably over 2 weeks. And I can find myself getting tired, I cannot do my walk anymore, I cannot walk to the top of my street without getting really, really short of breath. And if I keep on going and I push it, I stop, take a deep breath, and I keep on going. When I get done, I'm awful. And I said, you know, and And then I've gone what I call past the point of no return. Then I get to the point where sitting down doesn't help. I am short of breath all the time. But a lot of times if I try to go early, I get told that, you got air movement and you're not breathing.
Not sick and healthy.
Not sick enough yet. I need to find that optimum point, because I'm either not sick enough or why didn't you come sooner? Because I'll wait until it gets really bad.
Yeah, so, one of the things that I mention to my patients when I see them, or at least I try to mention to them, I'm not perfect, is check in with yourself every day, like you're doing, and figure out what is different. And I also tell my patients who, I've seen them a couple of times because they've gone in the hospital and they come back out, and then I'll see them right down the road. The number one thing that I seem to be hearing is, I'll say, well, when did all this start? What started all this? And they'll say, I just felt tired. I felt really tired for a few days, or I felt really sluggish. And then all of a sudden, I had to go in the hospital. So I tell folks, really look out for that, I'm just feeling really tired. And if that lasts for more than 24 hours, call your care provider and say, I really think something's going on. It's difficult as a provider because we sort of have to rely on signs and symptoms, and we may not always see that, but I think all of us as a profession are trying to get better and need to get better at listening to our patients, because we see a little snapshot of you. And sometimes I can look at somebody within 5 minutes and say, oh, this is what's going on, and I'm right. And sometimes I'm not. Sometimes I think that, oh, they're having your regular garden variety COPD exacerbation, I'm going to give them this prednisone, these antibiotics, and everything's going to be hunky-dory. And then it's not that. So, making sure to advocate for yourself like you are, and then just check in with yourself on a daily basis and say, okay, is today worse than yesterday? Is this a normal bad day for me? Or is this lasting a little bit longer, and maybe I should say something?
And one more thing that, I'm sorry, go ahead. The clinic, is it set up for things like, if you can't get in to see your doctor, that you can see the nurse practitioner?
Yes.
Because last week was the first time I had seen her, and that when I called, they said, well, Dr. Drury's not available till March something, and I was like, well, that's not gonna help me today. And they said, well, Megan can see you today, or tomorrow, or Monday. So that's what it's set up for, that days you can't see your physician?
Yes.
Okay, perfect, thank you.
This was touched on early on, but it's rescue inhaler. And as an asthmatic, I have stress or exertion-induced asthma. And the solution for me was to pre-treat. And I can make my walk, I can do what I want to do.
Oh, I've done that, yeah.
But you don't do it
Normally it does,
consistently.
normally it does, but the past couple weeks I have not been able, even, because I have a nebulizer at home as well.
Yes, ma'am.
Can you tell us more about the hereditary gene and respiratory?
Yes, I will. So alpha-1 antitrypsin is a substance that, I think, is it an enzyme? Yeah. It's an enzyme that's in your lungs and in your liver. And some people carry a genetic abnormality that causes them to be deficient in this enzyme. And if you're deficient in that particular enzyme, you are more likely to develop COPD. So, what we do in our clinic is we have a free screening kit. We will screen patients to see if they carry the genetic abnormality for alpha-1 antitrypsin deficiency. If you do have a deficiency, there is a replacement therapy depending on your levels. Some people carry the genetic abnormality, but their alpha-1 levels are still fine. Some people carry the genetic abnormality and their alpha-1 levels are low enough that we need to replace them and bump them up, and it helps curb a little bit of the progression of COPD, and it can help you make your symptoms a lot more manageable.
How do you help? What is the thing you do?
The thing that you do, so we do a finger prick and we check to see if you have that genetic abnormality, and to replace alpha-1, there are a couple of products on the market that are IV infusions, so you would get an infusion of this alpha-1, it's synthetic alpha-1.
You do it in the office?
Yes, we do.
We had a company come here last year and do just that. The question I've got is if we have enough interest, would that be something that you would be willing to do maybe before this meeting? Or
Yeah, we could definitely do it, and there's a rep who I'm sure would be very excited to do that. Alpha 1 is sort of you may have heard about people in the medical field talk about horses and zebras and how you have to look for the zebras. Alpha 1 is a bit of a zebra, and so I caution my patients to say, if we do this test and we find that you are Alpha 1 deficient, it's not a panacea. Replacing your Alpha 1 is not going to all of a sudden cure you and make you so that everything is right in your world. It can help inform your decision making as you treat your COPD, and sometimes replacement therapy can be very helpful in the right patients. I'm hesitant to tell people, oh, you know what, if we find that you are Alpha 1 deficient, then that is why you have COPD, because usually it's not, but it's something that we like to rule out, and then we like to make sure that we're covering our bases, because having that severe Alpha 1 antitrypsin deficiency can really complicate your COPD course. Does that make sense? But yes, I'm sure she would be happy to bring the test kits, and we could probably figure out a way for my medical assistant to come, and the two of us could just kind of fill everybody's paperwork out and send them off. The thing that we would want to make sure is that, you have follow-up with someone, because doing the screening, the results would come to our office most likely. Otherwise, they probably just get sent home, and I don't know about y'all, but sometimes I get medical results in the mail, and I'm like, well, what does this mean? And you kind of have to decipher it. You have to have somebody who specializes in it to decipher it. So we could talk more about that.
How common is that for people to have that? Is it?
I do not know the
It's
exact-
pretty rare.
Is it rare?
It's
That's what I
pretty
thought.
rare.
Well, and there is probably an age that, not to say that you two ladies, and even myself, if you haven't really been discovered, I would think at 60 it'd be pretty rare to make a diagnosis. Because I got it done while we were here, and I went to the doctor, and he said, "Did I order Alpha 1 on you?" I said, "Oh, they were at our meeting. I just did it. I wasn't expecting a positive." But he was like thinking he missed the whole conversation that we might have had regarding symptoms, and so it was kind of funny. But most people are in their 40s, younger, or I'd say if you haven't been diagnosed by 40s, it's really hard to say. Not to say it wouldn't
You'll still
be.
carry the diagnosis, you'll still carry the genetic.
You could carry the thing, and we might not see any symptoms, right?
What are symptoms?
The same kind of,
The
aren't
same
they?
as symptoms of COPD.
But you can have other organs affected.
You can, your liver
Liver,
can be affected.
yes.
But a lot of times the replacement therapy, there's a very narrow window of people that the replacement therapy is appropriate for, and the reason we say that is because you could replace all of your Alpha 1, but you will still have COPD. A lot of my patients, particularly who are 70 or older, a lot of times the reason we talk a lot about it is because if you carry this genetic abnormality, then your children might. And if they're still smoking, it's important to educate them to say, hey, you're carrying this genetic abnormality that makes you more likely to develop COPD. So it may be sort of a motivator to stop smoking.
One other thing that's often in the testing is both on chest X-ray, but particularly CT scan. If you remember in the beginning of the video that talked about the air sacs that kind of pop and become thinner and become larger and larger, you'll see a lot of that Alpha 1. And you'll look at a chest X-ray and you'll see these big, almost like balloon-looking black holes. And it's where there's no lung tissue at all. And it's where so many of those alveoli have kind of popped and coalesced together that there's now a gigantic air sac instead of lots of little tiny air sacs. We call those blood formations, and we see them a lot Alpha 1 and very severe emphysema. And they have a particular look on the really severe on chest X-ray, but particular chest CT scan. So if you've had scans, there are certain things that they would see. But again, like Caroline said, if there's damage to the lung, there's damage to the lung. You're not going to undamage the lung. If you catch this early enough, you can treat and mediate the symptoms. But again, if you know you have this deficiency, and you know that it can be genetic, making sure that family members are educated. So if we have a patient that has it, we try to make sure that their family gets tested. If anyone in their family is a smoker, to stop and to avoid irritants and those kind of things.
build up on your heart, you have the same symptoms she's talking about? Or does
It
that-
can, yes, it can, that's why it can be
Cause
sort
that
of
can
tricky.
make breathing,
It can make breathing very difficult. If you have fluid in your heart or in your lungs, or if your heart's just not quite squeezing the way it should, then you can have fluid build up in your whole body.
did you check that?
I'm sorry.
Did you check your fluid build up with your heart?
Any other
I
questions?
think that's
Chest out. Yeah, chest out, how important.
Mhm.
How important to individuals COPD to know what blood oxygen is on a daily basis? Mine generally stays the same. I haven't had this aspiration a couple of years. When
It
I
did it
had,
for you.
when I've had it, I've noticed it will take a nosedive. And I can see the relationship.
So, yes, there definitely can be a relationship. So checking your oxygen level once a day, every day, is a great thing to do, especially if you understand what it's supposed to be. I have some patients who check their oxygen levels all day, every day, and they get sort of fixated on it. And that can be problematic because, well, first of all, monitors aren't always super accurate. Sometimes they can get a fluke reading. And so, you know, I've put a pulse oximeter on my finger before and it said 76 because I have cold hands. That being said, checking your oxygen level